Pneumonia is an infection of the lower respiratory tract that can be caused by many microorganisms such as bacteria, viruses, fungi, protozoa, and parasites. In the United States, the most common cause of viral pneumonia is respiratory syncytial virus, and the most common cause of bacterial pneumonia is Streptococcus pneumoniae. Other common causes include, but are not limited to, are influenza, pneumocystis pneumonia, rhinovirus, adenoviruses, and whooping cough. Pneumonia can be classified by its microbiologic cause, host condition, and host settings. The five most common classifications are community-acquired, hospital-acquired, ventilator-associated, healthcare-associated, and pneumonia in an immunocompromised patient. Community-acquired pneumonia occurs in the community or within the first 48 hours after hospitalization, while hospitalized acquired pneumonia presents an onset of symptoms within the first 48 hours of admission. Ventilator-associated pneumonia is a type of hospital-acquired pneumonia that occurs through endotracheal intubation and mechanical ventilation. Healthcare pneumonia occurs in non-hospitalized patients who haven't had an extensive healthcare contact, and it can also occur in those who are immunocompromised or are taking immunosuppressive agents. Pneumonia is an infection that can cause many complications. According to the Centers for Disease Control and Prevention of 2018, 1 million people seek out healthcare related to pneumonia in the U.S., and 50,000 people die each year from it. Linda Honan also reports that 1% of the population is affected by it, and 1.25 million hospitalizations occur per year as a result of it. These numbers do not include all hospital and ventilator-associated pneumonias, making this respiratory infection even more prevalent. In general, the CDC reports that it is the 8th leading cause of death in the U.S. However, according to the American Thoracic Society, for children under 5 years old, it is considered one of the leading causes of death and accounts for 16% of deaths in the world. The same source also reports pneumonia is less fatal for children in the U.S. However, it is still the number one most common reason for children to seek care and become hospitalized. Pneumonia is considered to be a persistent threat. As shown on this slide, there are many numbers describing how many people are affected by this problem. If pneumonia remains undiagnosed, untreated, or worsens, it can lead to sepsis or septic shock. It's been reported by the American Thoracic Society that 50% of all episodes of sepsis and septic shock were a result of pneumonia. The persistence of pneumonia can also contribute to antibiotic resistance and place a burden on the healthcare system and costs. As stated before, pneumonia is an infection of the lungs and the lower respiratory tract. The microbes can enter the lower airways and infiltrate the alveoli through a variety of vectors. Such vectors include the normal flora in patients whose resistance has been altered, the aspiration of flora that is present in the nasopharynx or oropharynx, the inhalation of airborne microorganisms such as sneezing, coughing, or talking, contaminated water sources and respiratory equipment, and bloodborne organisms that enter the pulmonary circulation. When the microbes are identified in the lower lungs by the immune system, it activates an inflammatory response. This leads to an accumulation of white blood cells, exudate fluid, and immune complexes that migrate towards the site and create alveolar edema and lung tissue consolidation. When white blood cells, fluid, and immune complexes accumulate, they cause the alveolar and bronchial tissues to swell. This interferes with the normal ventilation and perfusion process and interferes with oxygen and carbon dioxide diffusion. The typical symptoms that one sees with pneumonia is fever, cough, whether that's productive or non-productive, dyspnea, and elevated WBCs. Other symptoms that can follow include pleuritic chest pain, tachypnea, use of accessory muscles, tachycardia, fatigue, and anorexia. A nurse will first assess the patient's presenting and onset of symptoms as discussed in the previous slide. The nurse should then perform a respiratory assessment. Upon auscultation of the lungs, pneumonia can cause bronchial breath sounds or crackles to be present because of the accumulation of fluid. Other physical assessment findings that indicate pneumonia are increased tactile firmitis, dullness percussion, egophony, and whispered pectoral illiqui. While the patient is under the nurse's care, the nurse should monitor the patient for the following changes: changes in temperature and pulse, the amount, odor, consistency, and color of secretions, frequency and severity of cough, degree of tachypnea or shortness of breath, pulse oximetry, changes in physical assessment findings, changes in X-ray findings, and white blood cell changes. It's also important to note that symptoms of pneumonia are like symptoms of COPD. Therefore, it is important to look for purulent sputum in COPD patients. In addition, it is important to monitor individuals, especially adults or older adults, for signs of altered mental status, dehydration, or unusual behavior because pneumonia can cause hypoxia. There are many nursing diagnoses related to pneumonia. The ones included in this PowerPoint are diagnoses that are critical and deal with the ABCs and Maslow's hierarchy of needs, but are not all of the nursing diagnoses that could be reported for a patient with pneumonia. The first diagnosis is ineffective airway clearance related to inflammation and presence of secretions. An outcome for this patient is to have improved airway patency and clearance and to demonstrate effective breathing and reduce secretions. The nurse should encourage deep breathing and controlled coughing. This is where a patient inhales deeply, holds their breath for several seconds, and coughs 2 or 3 times with their mouth open while tightening the upper abdominal muscles. According to a study provided by the Nursing Diagnosis Handbook, the authors report that deep breathing and controlled coughing use diaphragmatic muscles to make coughing more forceful in order to expel the secretions. In addition to this intervention, tolerated ambulation is beneficial because the movement helps mobilize secretions. Humidified oxygen, chest physiotherapy, and 2 liters of fluid per day help loosen up secretions and keep the mucous membranes from drying so that ciliary action can occur to move these secretions upward. To evaluate the patient that has improved airway, the nurse can assess the patient's cough for productiveness and normal breath sounds. Impaired gas exchange related to decreased functional lung tissue is another diagnosis for pneumonia. The patient outcome is to demonstrate improved ventilation and adequate oxygenation. Throughout hospitalization, the nurse will monitor the patient's respiratory rate and depth, auscultate lung sounds, and monitor oxygen saturation and level of consciousness. An intervention that encourages improved ventilation and oxygenation is through the administration of humidified oxygen to prevent hypoxia. According to a study published in the American Journal of Medical Sciences in 2015, high-flow nasal cannula helps improve oxygenation in those in acute respiratory distress. According to another journal article provided by the author Dr. Anchala in 2016, a semifowler's position improves oxygen saturation to help prevent hypoxemia, desaturation, and respiratory insufficiency. Evaluation of outcomes include that the patient demonstrates improved ventilation and adequate oxygenation as evidenced by ABG levels and oxygen saturation that are within normal parameters for the client. Patients with pneumonia are also encouraged to perform moderate activity in order to promote lung expansion and mobilize secretions. However, because patients with pneumonia can become weak and easily fatigued, another nursing diagnosis for them can be activity intolerance related to impaired respiratory function. It is important that nurses encourage frequent rest periods and to avoid activities that will lead to overexertion because these high energy activities can lead to an exacerbation of symptoms. Another patient goal is for them to demonstrate increased tolerance to activity. The nurse can begin helping this patient towards this goal by assessing for signs of intolerance such as dizziness, nausea, pallor, and a change in vital signs. The nurse can also educate the patient to take time when changing positions and to dangle their feet over the bed in order to prevent orthostatic hypotension. This is important because when a person rises to a standing position, blood pools in the lower extremities and hypoperfusion can occur, leading to feelings of weakness, nausea, headache, lightheadedness, dizziness, fatigue, and impaired cognition. Another evidence-based rationale behind taking the time to change positions is supported by author Guadalupe Durantes Mendez in 2013 and explains that a reduction in plasma volume associated with bed rest impacts the physiological responses of autonomic control of circulation, which can be demonstrated by a change in vital signs. In addition to these interventions, the nurse can also help the patient perform range of motion exercises if they are too weak to get out of bed or if their symptoms have not subsided. Evaluation of patient outcomes can include that the patient rests and conserves energy by remaining in bed while symptomatic, and then beginning to participate and tolerate in moderate activities slowly. This can be evidenced by reduced incidences of dizziness, fatigue, and lightheadedness. Another nursing diagnosis is risk for deficient fluid volume related to fever and rapid respiratory rate. The nurse can help promote the maintenance of proper fluid volume by encouraging hydration of 2 liters per day and watching for signs of hypovolemia, such as thirst, restlessness, headache, and inability to concentrate. The nurse will also monitor blood pressure, pulse, temperature, and level of consciousness because a change in these parameters can be associated with dehydration. The nurse should also monitor for signs of cyanosis, cold clammy skin, weak thready pulse, confusion, and oliguria, because this indicates that the body has compensated for the fluid loss by moving fluid from the interstitial space and into the vascular compartment. Other interventions the nurse can implement is to record strict I's and O's, observe for a urine output of 0.5 milliliters per kilogram per hour, and weigh the patient each day to monitor for fluid loss. A change of 1 kilogram indicates a fluid loss of 1 liter. According to the article, Oliguria in Critically Ill Patients, a Narrative Review, Sebastian Klein reported that it is important to observe for the amount of urine each hour because if not, it can lead to decreased renal perfusion and can lead to acute kidney injury. The evaluation of these outcomes is that the patient is able to maintain adequate fluid intake, a urine output of 0.5 milliliters per kilogram per hour, and demonstrates normal skin turgor. The last diagnosis I wanted to go over was deficient knowledge about the treatment regimen and preventative health measures. It is not necessarily an urgent need when creating a care plan for a patient, but it is important to educate patients on how to manage symptoms and how to prevent recurrences of pneumonia. Interventions should consider the patient's health literacy level and the format in which they learn best, whether that is through visual demonstration or verbalization. The nurse can provide education about signs and symptoms and when to seek care, also about the risk factors for pneumonia like smoking and alcohol abuse, and teach them about the purpose of their management, the purpose of activity and exercise, and the importance of medication adherence and hydration. Nurses will evaluate patient outcomes by having the patient verbally explain management strategies and also demonstrate that they are complying with these strategies. Moving forward in my nursing practice, reviewing this material has helped emphasize the specific information that can be used to help recognize pneumonia in a clinical setting. By noting the signs and symptoms, interventions, and treatment options, I will have a better time differentiating pneumonia between other respiratory illnesses such as COPD, chronic bronchitis, emphysema, and cystic fibrosis. This will also help me know what type of education is needed for a patient with pneumonia. This was a respiratory complication I've had trouble with in the past, and reviewing the signs and symptoms and nursing process has helped me understand it better. I hope this has helped you too.